This is chapter 63. We're going to be talking about thyroid and parathyroid glands in individual. I put a picture on here of kind of where everything is located, where your thyroid glands and your parathyroid glands are located just directly behind them. They kind of look like little pea-sized glands right behind the thyroid gland. So your thyroid gland and your parathyroid glands both secrete hormones, and the hormones that they secrete can affect many of your systems in your body, including your metabolism, your thermoregulation. So that's basically how our body regulates our temperature and other factors, our nutritional status, electrolyte balance, and then what we call excitable membrane activity. That's activity that's located within your central nervous system. We're going to talk about hyperthyroidism, and I'll do another short slide for you, or excuse me, video for you for your hypothyroidism. So there are multiple types of hyperthyroidism. Your first one is called thyrotoxicosis, and thyrotoxicosis is basically where there is an overproduction of your thyroid hormones. Hyperthyroidism itself is an excessive thyroid secretion. So you can have a secretion to where the thyroid glands are just slowly but surely secreting more hormones than they need to, and then the thyrotoxicosis is an actual overproduction of those thyroid glands. Thyrotoxicosis can occur when with many different functions. You see it sometimes with inside of Graves' disease, and you have several different hormones. Your TSH hormone and your TSI hormones can attach to the thyroid tissues, and the thyroid gland will start responding by increasing your glandular cells, which enlarges the thyroid gland itself, which forms a goiter, and I have a picture of this in just a moment. And when that goiter starts to form, that's when you see the overproduction of the thyroid hormones, and that's what causes the thyrotoxicosis. So it's basically all of these antibodies secreting more and more and more, and then the thyroid gland is overproducing, and so that's where the thyrotoxicosis comes from. Graves' disease is the most common form of your hyperthyroidism. It is an autoimmune disorder, and with Graves' disease, you see all of the general signs and symptoms of hyperthyroidism. Now, I'm not going to go over all of the signs and symptoms. I do have a slide coming up next, and there's also a chart on page 1286 that goes over, because there are multiple signs and symptoms that go over just about every part of your body. But look at your hyperthyroidism as kind of like when you rev up an engine. When you rev up that engine, it just continues to go faster and faster. That's kind of how hyperthyroidism is. You can have things like palpitations and weight loss and excessive diaphoresis. Your metabolic rate is increased. Women can have amenorrhea, which is a loss of their periods. Goiters are common, blurred or double vision, eye fatigue, and then, of course, the exophthalmos, the bug-eyed, you can have with hyperthyroidism as well. So, like I said, just kind of think of it as revving up that engine. So with pretibial myxedema, that goes a lot along with Graves' disease. It is a swelling of the front surfaces of your lower legs. It can kind of resemble like little benign tumors or keloid surfaces, and it's just a dry waxing swelling. It's not like your normal swelling, and not all patients that have a goiter will have hyperthyroidism. It can be caused from other problems. So how are we going to assess this particular patient because they have so many changes and problems with all the body systems. A lot of these can occur over a really long period of time, and most patients aren't aware of them. So you want to record your patient's age and gender and what their usual weight is. Because you do have an increased metabolic rate, it can affect nutrition. They can report an unplanned weight loss, increased appetite, or an increase in the number of bowel movements per day. The hallmark symptom you will see of hyperthyroidism is the poor thermoregulation, because they have heat intolerance. Even though it can be 60 or 70 degrees, these patients may think it feels significantly warmer. They have a lot of increased sweating, and they often, may wear lighter clothing even in colder temperatures. Visual changes may be the earliest problem as well, especially the exophthalmos, especially with Graves' disease. They can have blurring or double vision and tiring of the eyes. So, ask how their change of energy has been, whether they can perform their activities of daily living, and realize fatigue and insomnia are also common as well. We've already kind of talked about that's a lot of the history and the signs and symptoms. With the physical assessment, again, exophthalmos is most common in patients with Graves' disease. And also ask about light sensitivity, called photophobia. Two other eye problems you can see are eye retraction, is also called an eyelid lag, and then an eyeball lag. In the eyelid lag, the upper eyelid fails to come down when the patient gazes slowly upward. That eyelid doesn't descend back. In the globe lag, the upper eyelid pulls back faster than the eyeball when the patient gazes upward. So ask the patient to look, of course, up and down and kind of document that response. Under your clinical manifestations, again, there's a really nice chart on page 63.1, and there's also a chart on this next chart that I'm going to go over. The psychosocial assessment, these patients can have a lot of wide mood swings, irritability, decreased attention span. Like I said, their metabolic rate is in high gear. The hyperactivity can lead to fatigue because they're just kind of constantly going. They don't sleep well. And then they can describe their moods as either going full speed ahead or completely stopped. So, we want to be assessing this pretty well, and the patient's families or them can often report a change in their mental or emotional status. So here's your nice little chart, and again, we'll be talking about hypothyroidism in one of the next videos, but this goes over pretty well your hyperthyroidism, and I just went over a lot of those signs and symptoms. This is a nice picture of the exophthalmos. We used to call it, when I was younger, bug eyes, but as you can see, those eyes just protrude out of the eye sockets. This is a picture of a goiter. It really just kind of looks like that entire neck is swollen, but you can actually feel the hardness of the thyroid gland there. So kind of what laboratory testings we're going to be using. The most often tests you will see are the T3, T4, and your TSH. T3 is your triiodothyronine. T4 is thyroxine. TSH is, of course, your thyroid stimulating hormone. And then the TRABSs are your antibodies to the TSH receptor. You don't have to know specifically what all of these do. Just know, again, that you'll generally see your T3, T4, and TSH. And if you will look at the chart on page 1288, it explains to you whether these values are increased or decreased depending upon whether they're in hyperthyroidism or hypothyroidism. But if you can also remember that with hyper, everything is revved up. You're pushing that gas pedal in. It's revving up. So the majority of your T3, T4 are going to be increased because it's hyper. And then with hypo, everything is slowing down. So those lab values are going to be decreased. It's a little bit different with your TSH, but with your T3 and T4, you can kind of put them as increased, depending upon whether it's hyper or hypothyroidism. Okay. You can also do an ultrasound to check the thyroid out. The ultrasound helps determine in the thyroid gland size and generally if there are any masses or nodules. This is a painless procedure. It takes about 30 minutes. And then, of course, you'd want to do an EKG to look and see how the heart is doing. Your EKG will generally show tachycardia. Other things that you can see are atrial fibrillation, any type of other dysrhythmias, and then changes in the P and the T waveforms. Just going back real quickly, I did mention that Graves' disease is the most common form of hyperthyroidism, and that you generally will see most of the signs and symptoms of hyperthyroidism. But again, just remember that exophthalmos and pretibial myxedema are specific to Graves' disease. Okay? All right. So non-surgical management of a thyroid disorder. Monitoring, that just basically means that we're looking and watching for the patient's blood pressure and temperature, especially in the hospital setting, every 4 hours. Patients need to report any type of palpitation, shortness of breath, chest pain. An increase in temperature, even 1 degree, can indicate a rapid state worsening of the patient's condition and can indicate the onset of thyroid storm. Thyroid storm is a life-threatening event that comes up with uncontrolled hypertension. And thyroid storm is characterized by a very high fever and severe hypertension. Like I said, even 1 degree Fahrenheit of their temperature can report the impending onset of thyroid storm. Tasks that you can assign to an unlicensed personnel, of course, having them report the patient's temperature as soon as it's been obtained. And then if it's elevated, then you need, as a nurse, need to go assess the patient's cardiac status. You want to be checking for the cardiac monitor for dysrhythmias, again, for the atrial fibrillation. And things that we can do to help promote comfort, reduce stimulation in the room, have the patient rest, put off any type of procedures that you can do that for the patient. Keep the environment as quiet as possible, closing the door, limiting visitors, and just make sure the room temperature is to their comfort. Always make sure the patient has a fresh pitcher of water, and then change the bed linen. Of course, if they're diaphoresing a lot, then making sure you're keeping the bed linen changed. And also, cool showers and sponge baths can help with the comfort level as well. Drug therapy, we're going to be doing antithyroid drugs, of course, iodine preparations. Another thing to remember is the way that thyroid hormones work and the thyroid gland works is it basically takes food from the iodine, takes iodine from the food that you take in, it adds amino acids, and that's how your T3 and T4 are formed. And that's just kind of a real basic explanation of that. But that's why iodine is so important to the thyroid gland, that you must have enough iodine for all of those hormones to be working properly. I'm not going to expect you to really remember all of these medications, but Tapasol is one of the medications they use, and then also PTU. But you'll see Tapasol a lot with hyperthyroidism. These drugs help block the thyroid hormone production by preventing iodine binding in the thyroid gland. So again, we said the thyroid toxicosis is an overproduction of the thyroid hormone. So that's what these drugs do, is they help, prevent that hormone production of being so high. The surgical management. Surgical management with We can do a total or a subtotal thyroidectomy. That means we're either removing all of it, which is the total, or just part of it, which is the subthyroid part. This helps to decrease the production of the thyroid hormones. And remember that if the patient has all of the thyroid taken out, the total, then the patients have to be on a lifelong thyroid hormone replacement. If they just have a subtotal, then generally they will be on thyroid hormone replacement for about 3 months or so. Some of the post-op complications can be, of course, hemorrhaging, respiratory distress, hypocalcemic and tetany. They can have laryngeal nerve damage, thyroid storm, which again is what I said, we talked about a minute ago, is that life-threatening complication where they have a high fever and severe uncontrolled hypertension. Thyroid crisis is where it's not quite to where it's gone to the storm part yet. With the crisis part, so thyroid storm and thyroid crisis basically are the same thing. And again, just watch for fever, tachycardia, and then that hypertension. The reasons that these side effects will develop very quickly, it can be triggered by trauma, infection, diabetic ketoacidosis, or pregnancy. Other things that can lead to this, if you're palpating on a goiter rather vigorously, exposure to iodine, or radioactive iodine therapy. Radioactive iodine therapy is oral therapy. It's where they will have you take an iodine pill basically, and it tells how the uptake of iodine in the body is. It's less common after surgery, but it can still occur. And then, of course, eye and vision problems of Graves' disease, exophthalmos, vision, blurred vision can be complications as well. So post-operative monitoring, we're going to monitor for hoarseness or stridor, the suture line pressure there. Hypocalcemia is very common because you have removed that thyroid gland, and then, of course, the thyroid storm. One thing I didn't mention, if you don't know what tetany is, it's what they call a hyperexcitability of your nerves and muscles. It's basically muscle twitching that comes from the CNS involvement with the thyroid. Thyroiditis is an inflammation of the thyroid gland. You have 3 types: your subacute, your chronic, which is the Hashimoto's disease. That's the most common. And I really didn't go into Hashimoto's disease a lot, but Hashimoto's is basically just another, it causes Graves' disease, and it results in the production of autoantibodies to different substances and structures within the thyroid gland. I don't really expect you to have to remember that. With thyroiditis, again, it's an inflammation of the thyroid gland. And the acute thyroiditis, this is all you need to remember, is caused by a bacterial invasion. So you've got bacteria in there. You can see pain and neck tenderness, malaise, fever, and of course difficulty swallowing. It's resolved with antibiotic therapy. The subacute, or the granulomatosis, is a viral infection. You can see it after a cold or an upper respiratory infection. That's fever, chills, dysphagia, muscle and joint pain. Most of the time the thyroid function is normal, although hyperthyroid or hypo can develop. And then the chronic is a common type, and it can affect women more than men. Usually occurs with patients in their 30s to 50s. And that's really all you have to remember with thyroiditis. It's, for the most part, non-surgical management. You basically treat the symptoms, and If surgical management was needed, it would be the same along the lines as a subtotal thyroidectomy or a total thyroidectomy. Thyroid cancer, I'm going to keep this pretty straight and to the point, and I'm going to go ahead and show you the next slide, which has all the information on it for you. This goes over the basic of thyroid cancer. There are 4 different types: your papillary, follicular, medullary, and anaplastic. Your initial sign of thyroid cancer is a single painless lump or nodule in your thyroid gland. Again, realize that is painless, and the signs and symptoms kind of come with where it's located and whether it has spread or not. Your papillary, as it says on here, is your most common, occurs in younger women. It's slow growing and it can be present for many years before spreading. This one has a pretty good chance for cure. Your follicular occurs most often in older adults, like your 70s and 80s. It invades the blood vessels. It spreads to the bone and lung tissue, and it can attach to your trachea, neck muscles, skin. It results in a lot of difficulty breathing and difficulty swallowing, and the patient can have a hoarse voice. Medullary is the most common in patients older than 50. You often see it as a part of other multiple endocrine problems. The tumor usually secretes calcitonin and ACTH, prostaglandins, and serotonin. Your anaplastic carcinoma is rapid growing, most aggressive, and it metastasizes and invades nearby structures. So this is one that's very rare. You will hear stridor, that's the harsh, hard-pitched respiratory sounds, hoarseness, and dysphagia. And your hallmark lab value with thyroid cancer is an elevated serum thyroglobulin level, or a TG level. And your normal for men is 0.5 to 53, and your normal for women is 0.5 to 43. With thyroid cancer, you can have surgery. Surgery is the treatment of choice, doing a total thyroidectomy, getting rid of it. And then the patient will be on suppressive thyroid hormones for at least 3 months after surgery. And then if they will do lab work, and if it continues to rise, then that means that some of the cancer cells are left. They can do what they call ablative therapy with radioactive iodine, and that's the one I told you they would just take the oral pill and see how much iodine is being secreted in those glands. And those are the most common ways that we see for this to be dealt with. If it is severe enough and taking the thyroid gland out, they may do chemotherapy. So just a real quick review on hyperparathyroidism. Your parathyroid glands, they help regulate your calcium and your phosphate balance. So with your parathyroid gland, with hyperparathyroidism, these processes can cause hypercalcemia and hypophosphatemia. So you have excess calcium and not enough blood phosphorus. Realize with hyperparathyroidism, the patient is more at risk for osteoporosis, because the PTH levels increase the bone resorption. So basically, the osteoclasts are breaking down more, and then the osteoblast, the bone production, are not able to keep up. So it's, like I said, it's a lot like osteoporosis. This releases calcium and phosphorus into the blood and reduces your bone density. They don't really know what causes this, but the most common cause can be a benign tumor in the parathyroid gland. Again, you'll see, just remember that you're going to see increased calcium and decreased phosphate level. Surgical management is the choice for patients with hyperparathyroidism, and they go in there and take out those parathyroid glands. And that's all that you really have to remember about that. Actually, I'm going to look over the Tchaikovsky sign and the Trousseau sign. And just remember that your Chavostic sign is abnormal facial spasms when you're lightly tapping on the cheek. The Trousseau sign is an involuntary flexion caused by inflating a blood pressure cuff. And it just, the Trousseau sign occurs in clients with hypocalcemia or hypomagnesium. And that's all you have to remember. So this is the end of this particular video. Have a good evening.